Welcome. Today we're learning how to conduct a tabletop exercise for emergency preparedness. This brief 15 minutes training is brought to you by Public Health Prepared and Region 5 Public Health Training Center. Today we will cover what is a tabletop, how do we run one, and what do we do after. Let's start with some definitions. These are the key definitions. What's a tabletop exercise? What are cross-sectoral partners? And what's ICS, the Incident Command System? A tabletop exercise is a discussion-based simulation. Participants sit around the table and talk through how they would respond in an emergency. No real resources deployed, no real activation. It's low cost, low stress, and incredibly valuable for finding gaps in plans. Cross-sectoral partners are the different organizations that must coordinate during emergencies, like public health, emergency management, EMS, hospitals, schools, nonprofits, and utilities. A tabletop brings them all together in one room. The ICS, Incident Command System, is the standardized structure we use to manage emergencies. It is clear chain of command and defined roles. During a tabletop, you will test whether people understand their ICS roles and how to coordinate within that structure. Now, let's see our objectives. By end of this video, you will be able to describe the 6 core components of a tabletop exercise and understand how they will work together. Engage through an ice storm scenario in Ann Arbor to practice real-world decision-making under pressure. Identify 1 to 2 immediate after actions once the exercise ends. Overview. So here are the 6 components of a tabletop. Think them of like a building block. 1. Background presentation. The facilitator sets the scene, the hazard, the community, and the current situation. 2. Inject. New information that moves the scenario forward. Something happens like power goes out. Case surges. Communication fails. 3. Small group discussion. Participants break into groups and talk through. What do we do now? Group discuss their actual roles and decisions. 4. Repeat injects and discussions. You cycle through multiple injects, new complications, escalating challenges, with group discussions after each one. 5. Large group synthesis. Bring everyone back together. Group shared decisions. You highlight gaps and interdependencies. 6. Hot wash. Immediate debrief while it's fresh. Ask what worked, what didn't, what surprised you, what would you change. And that's the flow. Now let's see it in action. Here is the scenario. We are in Ann Arbor, Michigan. Population 123,000 with another 50,000 students at University of Michigan during the school year. It's January 15th, 3 p.m. mid-semester. Key assets: University of Michigan Hospital, a 900-bed medical center with a level 1 trauma center, VA Ann Arbor healthcare system, and with other hospitals. Multiple adjunct care clinics, 2 nursing homes, numerous schools, and university facilities. Major highway I-94 runs through the area. The National Weather Service just issued an ice storm warning, freezing rain tonight through tomorrow evening. 0.4 to 0.7 inches of ice. Winds from 20 to 30 miles per hour, gusting to 45 mph. High likelihood of widespread power outage affecting the entire Washtenaw County region. Temperatures below freezing for 72 plus hours. Context. It's mid-flu season. University health services have reported increasing respiratory illness cases. U of M hospital is at 85% capacity. Multiple providers are out sick. And the power grid in the area hasn't experienced a major ice storm in a decade, and infrastructure has aged. Now you got it. Let's start the exercise. Background information. The facilitator presents the scenario. Participants ask clarifying questions. What's our generator capacity? Are schools open? Do we have any staffing issues? After 10 minutes of questions, the facilitator says, "Okay, everyone, everything is clear. Let's move forward in time." And then comes the first inject. It's now 10 p.m. Freezing rain has begun. 30% of the town has lost power, including the nursing home on the east side. Roads are icing. EMS reports delayed response times. 911 calls are increasing. Now, please pause this video and discuss with your group. Group discuss. How do you evacuate ICS? Who coordinates? What's your first action? One group says, "We open a warming shelter. We request mutual aid." Another group says, "We didn't think about mutual aid. Who do we contact?" "We don't have any procedure for that." Perfect. The gap was identified. Now let's move to the next inject. Second inject. It's 3 a.m. 60% of the town is without power, including the hospital, now on generators. The ED is surging with people needing warming and minor injuries. The second nursing home reports their backup generator is failing. They have 4 to 6 hours of heat left. Cell service is now poor, and the highway is closed. Please pause this video and discuss with your group what are your further actions. Group discuss. What's your priority? How do you handle the failing generators at the nursing homes? How do you move patients when roads are closed? Groups realize they don't know who decides to evacuate the nursing home. They don't have a backup communication plan. They don't have enough ambulances for mass evacuation. These are critical gaps identified. Now let's keep going and move on to the next inject. Third inject. It's 6 a.m. 75% of the town has no power. The ice storm continues for another 18 hours. Cell services is down, and only landline and radios work. The nursing home's generator failed. Temperatures inside the nursing home are unsafe. The hospital is at 95% capacity. Multiple 911 calls, but EMS can only respond to life-threatening emergencies. Pause this video and discuss with your group what are your further actions. Group discuss. Do you evacuate the nursing home? If yes, how? To where? How do you coordinate without cell phones? How are the city government and outside partners responding? What street resources do we request? Decisions. Evacuate immediately. Request assistance from neighboring cities and request the state to declare the disaster and activate the National Guard. Use ham radios until the communications is reinitiated. So now, as a large group, discuss. What did we decide? Everyone agreed to evacuate. But multiple groups asked, who has the authority to order evacuation? That's the gap. Our plan doesn't clarify this. Everyone struggled with communication. Realized we can't rely on cell phones. We don't have a list of vulnerable populations, people who are oxygen dependent, dialysis patients. How do we reach them? Now moving on to hot wash. Let's discuss what worked well, what didn't work well, what surprised you, what would you change tomorrow? What worked well? ICS structure was clear. People know who to report to. What didn't work? Authority for evacuation unclear. No backup communication system. No vulnerable population registry. What surprised you? How fast this can escalate? How dependent are we on cell phones and electricity? What will you change tomorrow? Write a clear evacuation triggers and authority. Get ham radios. Create a vulnerable population list. The facilitator records everything. This becomes the after action report. After action report. You write an after action report or improvement plan. It has 3 sections. What we tested, when, who participated, what are the objectives. For all the analysis, for each objective, did we achieve it? What worked? What were the gaps identified? And use specific examples from the exercise. Moving on to the improvement plan. This slide summarizes the key actions identified in our improvement plan, along with who is responsible and the proposed timelines. First, County Emergency Management and Public Health will work together to clarify evacuation authorities and protocols. This is a short-term priority to reduce confusion during the event. In parallel, County Emergency Management will establish a ham radio backup system to ensure communication continuity if primary system fails. Public Health will lead the creation of vulnerable population registry so at-risk individuals can be identified and supported during emergencies. We also identified the need to formally document mutual aid procedures, which will be coordinated by HCC coordinator to improve cross-agency response. Finally, all organizations will update their emergency operations plan and complete staff training to align with these changes. The next steps are to distribute this plan to stakeholders, track implementation, and test these updates in next exercise within 6 to 12 months. And coming on to our last slide. Resources. Scan this QR code to access the document list with relevant resources. Thank you.